Next speaker. So, weaning from ventilation and liberation from mechanical ventilation is an important process in critical care. It impacts the patient's mortality and morbidity. Now, we'll listen to Dr. Ganshyam, who is the Director of Critical Care in Medicover, Hyderabad. Over to you, Ganshyam.
When you look at different aspects of mechanical ventilation, I think the one aspect that you can be absolutely sure of, 100% guaranteed, is every patient that you're going to intubate is going to be finally weaned. Now, either the patient gets better and you extubate the patient gets weaned, or the patient dies and you eventually disconnect him from the ventilator, the patient gets weaned. Now, how does which way you want your patients to wean? Well, it depends upon the way you kind of look after him when he's in your ICU. Now, for a long time, we considered weaning as a gradual process, where we gradually decrease the respiratory support. We looked at whether the patient was ready to breathe. Then, if the patient is ready to breathe, you look at various factors which can interfere with his breathing process. Then you did a few trials, and then you looked at whether the patient would be extubated or not. Now, a lot of data has suggested that if you go through this route, then probably patients are going to spend a large amount of time unnecessarily. And that's where we have now started using the term liberation, where you see that a large number of patients need not go through this process. And that is something that we see day in, day out, isn't it? We see that patients, close to 75% of your patients can be extubated after the first spontaneous breathing trial, and they need not go through this entire process. So if I look at weaning or liberation, the only two things that matter to me is, one, what is happening to my primary pathology. The reason why I have intubated the patient is that primary disease under reasonable control, recovery or reversal. And the second thing that matters to me is the patient able to breathe? So probably the only two things which we all should look at is these two things. And with these two things, if you can avoid iatrogenic complications, we all know that when a patient is in the intensive care unit on a ventilator, there is scope for a lot of iatrogenic complications. It's something that we need to look at. And if we are looking at a predictor or a parameter or a strategy which is going to give you 100% success is weaning, unfortunately, we do not have any such predictor, any such physiological or a biochemical or a laboratory parameter which can tell you with 100% guarantee that this patient can be weaned or this patient cannot be weaned. So how do we look at ways, or how do we look at strategies by which you can optimize your weaning or liberation? One of the first things that we need to do is to look at the way you ventilate. Excuse me, figure is missing. Okay. So the way we ventilate our patients has a tremendous impact on whether the patient can be weaned or not. Now, both with respect to your ventilatory strategies which impact your lung injury, at the same time your ventilatory strategies which also have an impact on the diaphragmatic function. Now, there are very clear guidelines which have been established which look at the ventilation-induced lung injury, and we know that if you ventilate patients with very high tidal volumes, very high plateau pressures, high driving pressures, then you are going to contribute significantly to the ventilation-induced lung injury, and that can have a tremendous impact on your weaning. Similarly, there is a lot of data which is coming up which shows that if your ventilatory strategies are not appropriate, especially the way you allow your diaphragm to function, giving too much of respiratory support leads to diaphragm atrophy. At the same time, when you allow your patient to breathe when he is not ready, putting a significant load on the diaphragm can also lead to diaphragmatic injury. So you need to balance your ventilation in such a way that both your lung as your diaphragm are adequately protected, because these two things have a major role in how your patients are going to be weaned off the ventilator. Now again, the strategy which we need to look at is identify the reasons why patients fail weaning. And if you look at data, Your cardiorespiratory reasons are one of the major causes for weaning failure, and that is where role of ultrasound and echo in assessing weaning is coming up in a big way. We know that ultrasound and echo can identify majority of the reasons with respect to your respiratory function as well as with respect to your cardiac function, which can identify weaning. Fluid overload, pleural effusions, new onset consolidations, your diaphragmatic function, whether your lung aeration score is improving or not. We also know that whenever you put patients on a spontaneous breathing trial, it is kind of a cardiovascular stress, and a significant number of these patients with underlying coronary artery disease can have pulmonary edema, especially when you put them on spontaneous breathing trial. And that is where an echo or an ultrasound can help you identify which patients are landing up in pulmonary edema when you give a spontaneous breathing trial. Similarly, diastolic dysfunction is often an under-recognized reason for weaning failure, which can be easily identified at the bedside with the use of echocardiography. So please incorporate ultrasonography and echo into your weaning strategies whenever you subject a patient to a spontaneous breathing trial. Protocols are key, and if you look at data, uh, if you look at most of the literature with respect, if you look at data, be it with respect to respiratory failure or be it with respect to the management of other aspects of intensive care, it has been well established that if you have care which is guided by protocols, probably the outcomes are much better. So with respect to liberation from mechanical ventilator, the various aspects of ventilation, for example, the kind of mode you use, when do you subject the patient to a spontaneous breathing trial, who should do it, if you have a protocol which guides these things at your ICU, depending upon the infrastructure that you have, it could be a physician driven, it could be a respiratory therapy driven, it could be a nurse driven. Having a ventilator protocol which clearly guides about these principles can significantly decrease your length of mechanical ventilation stay. Similarly, if you look at sedation, we all know the impact of sedation on the duration of mechanical ventilation, on the incidence of delirium, which could be a significant factor in delayed weaning. Having a protocol where you interrupt the sedation on a daily basis, awaken the patient, and try to give him a spontaneous breathing trial, again has a tremendous impact on weaning. So, nutrition often an under-recognized aspect of critical care, but there is clear data to suggest that both underfeeding as well as overfeeding has an impact on getting patients off the ventilator. Lastly, we know that if a patient is immobilized, a patient lying down on the bed, there are significant negative impacts with respect to your muscle function, with respect to your immunity, with respect to the way the patient breathes. So having some sort of a protocol where you incorporate physiotherapy or rehabilitation right from the start, the patient is put on the ventilator, has been shown to have an effect where the duration of mechanical ventilation as well as the length of stay is reduced. Now, what kind of a rehabilitation protocol you want to have, whether you want to have a very intense or a standard approach, is entirely dependent on you. Intensive rehabilitation protocols have not shown to have any major advantage over the standard protocols. So depending upon the kind of infrastructure you have, depending upon the kind of manpower you have, you need to have some protocols which address these aspects of ventilation. Would you uh, would you want to use weaning indices? Sorry, all the pictures are missing. Uh, Weaning indices, they are pretty optional, because the major problem with weaning indices is none of the weaning indices has a very high sensitivity and specificity. Though F by VT is being the most commonly used, they don't exactly tell us whether the patient is going to tolerate extubation or not. So if you want to put somebody through the weaning index, you can do it. In my ICU, we don't usually follow the indices. Do newer modes help? Well, a lot of new ventilators are coming up with modes which can adapt to the changing ventilatory needs and give support based upon the patient's changes in the respiratory compliance or the resistance. Now, there are small trials which have shown benefit, but the major problem is these modes are not available in all the ventilators. I don't have any of these modes. I don't use them regularly. But if you have the facility, you can always try the newer modes, which seem to be very attractive, but do they really help in getting patients off the ventilator is still something that we need to see. Uh, well, spontaneous breathing trial is mandatory. Before you subject a patient to extubation, we need to look at whether the patient is able to breathe with the least support. How do we give it? Either through a CPAP, pressure support, or TPs. Again, it's a debate. The guidelines recommend that probably having some sort of inspiratory support is better than not having, whereas some believe that probably the TPs duplicates or replicates the real life conditions when the patient is off the ventilator. The only point we need to remember is you will not know whether a patient is going to tolerate a spontaneous breathing trial until and unless you give a SBT. So the best way of knowing whether the patient is going to tolerate an SBT is to give him a trial of SBT and then see if the patient succeeds and then subsequently go to extubation. Now before you extubate, yes, we need to check at cuff leak because patients who are in the ICU on the ventilator can have stridor secondary to the laryngeal edema. There are well-defined risk factors, especially if the patient has been intubated for more than 7 days, female sex, a large endotracheal tube size, patients who have a traumatic intubation, elderly. Now, these patients, there's a very, very high probability that they can end up with a laryngeal edema. And once you extubate, the patient may have stridor and may be the reason for reintubation. Unfortunately, there is nothing that can predict which patients are going to have a laryngeal edema or not. Cuff leak to some extent gives us an idea about the probability of a stridor after extubation. So if a patient fails your cuff leak test, then you have the, the chance of giving him steroids, a small dose of methylprednisolone, about 40 milligrams of methylprednisolone 4 hours before extubation has been shown to decrease the incidence of post-laryngeal, post-extubation stridor. Uh, well, again, when it comes to the process of extubation, you need to look at the ability of the patient to maintain a patent airway. Now, simple things like what is the patient's neurological status, whether the patient has adequate muscle strength, adequate cough to mobilize his secretions, and whether the patient has the ability to protect his airway. Now, if you look at a large number of neurological patients where the GCS is poor, they may still be able to tolerate or they may still be able to successfully go through a spontaneous breathing trial. But they may not be in a condition where you'll be able to extubate them for the only reason that their ability to protect their airway may not be appropriate. So in these patients, probably you should be looking at doing an early tracheostomy and getting them off the ventilator. Post-extubation, is there a role for high flow or NIV? Again, there is good amount of data and guidelines recommend that in those subset of patients where there is a high probability of post-extubation failure, such as patients with COPD, patients with hypercapnic respiratory failure, there seems to be a definitive role of giving NIV post-extubation. The only point we need to remember is if at all you want to give a trial of NIV, then it has to be given before the respiratory failure sets in. If you try to use NIV as a rescue therapy after you extubate the patient, then there is a higher probability that you're going to delay the required reintubation, and that can be associated with poor outcomes. If your patients don't tolerate spontaneous breathing trials and if they're failing repeatedly, then there's something called as inspiratory muscle training, which is coming up, where you can try to train your respiratory muscles. Now, there have been two strategies which have been suggested. One, where you try to adjust the trigger to about 20 to 40% of the PI max, or you can keep increasing your inspiratory threshold starting with about 20 to 50% of the PI max. The flip side of this is there are a lot of data which suggested that if you don't do it properly, then probably you are going to induce more amount of muscle fatigue. So there is still a concept which is being tried out, so something that can be looked upon if your patients don't tolerate weaning. So just to summarize, avoid unnecessary sedation. That is the key. Until and unless you wake them up, you will never know whether your patients are going to tolerate or are ready for weaning or not. Make sure that your ventilatory strategies focus on protecting the diaphragm, avoid excessive tidal volumes, excessive pressures. Daily screening for SBT is a must. Well, which SBT do you want to choose? I personally choose a pressure support based. We don't use TP's trials. So something that you can look at your own ICUs. Have protocols with respect to ventilator, with respect to sedation, with respect to physiotherapy, with respect to nutrition. They make a tremendous impact on weaning patients. And if the patient fails an SBT, don't wait. Get the patient back onto complete ventilatory support. uh, Pushing the patient when an SBT fails is not going to help you. Uh, Weaning versus extubation failure, you need to assess those patients who may tolerate spontaneous breathing trials but may still fail weaning because they are unable to maintain a patent airway post extubation. If you want to give support post extubation, then it has to be earlier. Don't wait till the patient goes into respiratory failure. And in those situations where the patient is able to breathe, but you have doubts about his ability to have a patent airway, then tracheostomy is the solution. Thank you.